So I am honored to be included in this ECHO series and participate in today's session. My talk is the second part of a two-part series featuring the topic of pediatric long COVID and ME/CFS. I am Amy Mooney and I am out of Chicago, but I do have licenses in multiple states. So reach out to me if you are finding that some of your patients may need OT. I may be able to help you. I do telehealth therapy. In this presentation, I will review Dr. Hoppers' Part 1 Long COVID in Children. And please refer to her recorded presentation for more information on symptoms, diagnosis, and comorbid conditions of long COVID. This recording can be found on ECHO's website. I will explore the details of long COVID and ME/CFS, including the severity levels and patients' lived experiences, understanding pacing for PEM, adaptations and modifications, analyzing activities and exertion stressors, and then finally rest strategies. I have no conflicts of interest for this presentation. Occupational therapy, or OT, and physical therapy are healthcare professionals that often intersect as they support patients in rehabilitation and skill building following injury, illness, or other disabling conditions. OT and PT goals focus on improving quality of life, but the therapeutic principles differ. We have different tools in our toolboxes. The therapeutic care for physical therapists focus on improving an individual's ability to carry out daily activities, typically using biometric or biomechanical strategies. Occupational therapy is dedicated to enhancing lives through meaningful and purposeful activities. OTs assist individuals in reestablishing or redefining their daily occupations due to health limitations. These occupations encompass essential roles and activities that define a person, such as being a family member, a student, or a friend. And ADLs and IADLs form the foundation of daily functioning to facilitate broader participation in home and community settings. When conditions like long COVID impact these activities, OTs and PTs help individuals understand how their symptoms and their conditions affect daily activities, allowing for strategies that support function and improve quality of life. Through my perspective as an OT, I aim to provide a pacing framework that OTs, PTs, and other allied health professionals, along with patients and caregivers, can use to bring structure to this debilitating, chronic, chaotic disease. I hope that I can offer you a window into the lives of those living with this chronic condition, specifically the pediatric population. The name myalgic encephalomyelitis or chronic fatigue syndrome, or ME/CFS, has a long and complex history. The name carries certain stigma. In this presentation, I will refer to it as ME for short. Similarly, long COVID and long COVID with PEM or PESE also have their own histories and associated stigmatization. Post-exertional malaise, or PEM, is commonly used in the ME community, while PESE, or post-exertion symptom exacerbation, is often referred to in the long COVID community. I aim to offer some insight into the differences between these diagnoses and terms in the following slides. Anyone can develop ME and long COVID with or without PEM, including adults and children. In this presentation, I would like to focus on children and their unique, often overlooked symptom presentation and its impact on the daily lives and future identities. Many adults describe feeling like a shell of their former selves. For children, they may not have the words to accurately express their symptoms and may be perceived as reacting with behaviors or defiance. However, what we have learned from children with ME as they grow older is they don't understand what being healthy was supposed to feel like. How can you describe an illness when you don't understand it or aren't believed? The impact of debilitating symptoms of ME and long COVID on children's occupations influence the development of their identities, creating a shell not only of their former lives, but also of their future dreams. In Dr. Hoppers' Part 1 presentation, Long COVID in Children, she explored the diagnosis and symptoms of long COVID and examined comorbid conditions such as Ehlers-Danlos syndrome or postural orthostatic tachycardia syndrome and mast cell activation syndrome. Dr. Hoppers and I collaborate on the care of many patients, most of whom are extremely complex and have lived with debilitating symptoms for years, often decades. Both Dr. Hoppers and I have a special interest in providing care for kids with ME and long COVID. We have seen firsthand how these children are especially vulnerable, disbelieved, and misunderstood. When the majority of the medical community and parents do not recognize the condition and there are no FDA-approved treatments available, it becomes challenging for kids to make sense of their symptoms and experiences. The multi-pronged approach for care includes pharmaceutical interventions for managing the symptoms of comorbid conditions, which Dr. Hoppers covered in Part 1. And in this Part 2, I will focus on the non-pharmacological approaches to managing symptoms and activities aimed at improving quality of life. So here's just a quick summary of one portion of Dr. Hoppers' presentation. COVID-19 infection can lead to a variety of outcomes. While the majority of individuals, both adults and children, will restore their health within a short period, others may experience a longer illness onset and lingering effects. It is estimated that 10 to 20% of children with COVID infections fall into this category, with many eventually returning to full health. However, a percentage of this group may develop conditions with long-lasting symptoms. We do not have a clear number for these children, but it is estimated that up to 50% of adults who experience symptoms lasting more than 3 months will fall into this third group. These individuals often exhibit hallmark symptoms of ME, PEM, and may go on to meet the diagnostic criteria for ME. Children and adults experience and describing long COVID symptoms differently. These charts represent groups with long COVID for over 3 months, combining both populations with and without PEM. It is not sensitive to an ME diagnostic criteria at this point. Both age groups commonly report tiredness, heaviness, and a lack of restorative rest. Children frequently mention abdominal and head pain, while adults report shortness of breath, heart palpitations, and cognitive dysfunction. Children may struggle to express their symptoms, but abdominal and head pain are more common in kids than adults. According to the IOM, the diagnostic criteria for ME includes 3 primary symptoms: a significant reduction in activity lasting at least 6 months for adults and 3 months for children, post-exertional malaise, or PEM. PEM is the worsening of all symptoms following physical, cognitive, social, or social-emotional exertion, lasting for days, weeks, or even longer, and unrefreshed, impaired sleep. Additionally, either cognitive impairment or orthostatic intolerance must be present. Here are some PEM screening questions that help providers determine if a patient has the hallmark symptom of PEM. Does it take more than 1 day to recover to baseline after activity? Do you feel unwell, weak, have poor sleep, or experience pain when recovering from this activity? Do you feel limited to your ability to perform normal daily tasks after activity? And another way of asking this point is, does exercise or physical activity affect you negatively? These questions can help identify whether a patient experiences PEM and then qualifies or meets the criteria for ME diagnosis. Pediatric patients with ME meet the criteria outlined in the previous slide, but often exhibit the following symptoms specific to their age: the reduction in activity, which may manifest as school absenteeism, and decreased participation in social activities. Orthostatic intolerance. This is more common in children, especially adolescents, although younger children may struggle to articulate these symptoms. It can be dizziness, lightheadedness, and fainting. Additional symptoms, like I said before, can be stomach pain, headaches, and also mood swings. There are 4 severity levels for ME. Those describing their ME as mild may engage in activities where their symptoms are not immediately evident. However, despite participating in events, they experience a crash, prompting a withdrawal from public view. Those in this category typically remain mobile and self-sufficient. They manage light domestic and ADL tasks, but with some difficulty. They perform employment or school duties, but with support. And they exhibit significant reduction in activities needing frequent breaks. The moderate level is looking at 50% reduction in pre-illness activity, unable to work or attend school, and what I would consider home tethered. And severe ME, unable to carry out minimal activities with moderate amount of assistance. They require daily caregiver assistance. They have severe cognitive difficulties. They need support for positioning and movement. And they are considered homebound, bed tethered, and very severe, unable to mobilize or carry out any ADLs for themselves. They need full-time assistance for basic functioning and positional care. They are extremely sensitive to stimuli. They are bedridden and have limited mobility. Understanding how patients describe PEM and therapeutic approach. PEM is characterized by intensified and disproportionate response to exertion, both immediate and delayed symptom exacerbation. Patients often use the terms like crash or relapse and collapse to describe PEM. They liken this experience to feeling as if they have run a marathon while simultaneously having the flu, a hangover, and then getting hit by a bus. They describe it as feeling poisoned or as if their body is being poured with cement. PEM is not simply deconditioning or fear avoidance behaviors. Instead, it involves a significant change in metabolic functioning. Studies have shown that the anaerobic threshold, the point at which the body switches from aerobic to anaerobic metabolism, has shifted in patients pre-COVID compared to their post-COVID infections. This means that a patient with PEM now reaches this threshold at a much lower level of exertion than before. When the anaerobic threshold is exceeded, lactate builds up in the bloodstream faster than it can be excreted. This accumulation of lactate leads to metabolic acidosis, causing symptoms like muscle pain, fatigue, and overall malaise. Essentially, patients are experiencing a form of metabolic poisoning, where their bodies are overwhelmed by rapid buildup of lactate, exacerbating their symptoms, otherwise known as a crash. So what does a crash look like and feel like in real life? Well, therapeutic principles of OT and PT have traditionally focused on observing and measuring how activities, exercise, and daily functions are performed. This approach emphasizes what is seen and what is measured. However, with PEM, the full consequence of activity or exercises are not often observed by the therapist and occur outside public view. A patient can perform the exercise in the clinic, but the consequences for the exertion typically manifests hours or days after the stressor, when the patient is home, in bed, and away from view. This hidden aspect of PEM can be likened to the portion of the iceberg that's below the surface. The true extent of PEM is only seen by close family and caregivers. Therapists may see a patient days or weeks after this initial stressor, but they do not witness the multi-system symptom response to PEM. Patients are usually too unwell to be out in public until their PEM symptoms have subsided. As an OT and a caregiver for a loved one with ME, I have worked hard to understand how the medical community often misses the essence of PEM, the crash. The therapeutic approach I developed using flipping the iceberg and focusing on what occurs between activities and how these activities impact baseline stability and functional capacity for activities of daily living. I refer to this therapeutic approach as pacing for PEM. Pacing is a strategy used for managing exertion over time. For purpose of this example, I'll describe three distinct categories of pacing. Pacing for individuals without significant health concerns, and this is everyday strategies for managing the responsibilities of your work, play, and leisure. And pacing for therapeutic strategies is tailored for those with an intact metabolism and without disease-causing post-exertional malaise. This approach involves a more intricate process, and with the guidance of a medical professional, individuals can assess and adjust their activity level. This is the typical rehab program of increasing strength, range of motion, and endurance that you might find in a clinic. Pacing for PEM, this category is tailored towards patients with impaired metabolic functioning. This is a specialized and crucial strategy involving managing activities, exertion, and rest over time. Pacing for PEM must consider exertion before, during, and after an activity, becoming a lifestyle approach for symptom management. The goals for pacing for PEM is establishing a stable baseline for functional performance and engaging in meaningful prioritized activities while minimizing symptomatic consequences. Pacing isn't about extremes. It's not about doing nothing or pushing through and dealing with the crash later, like the boom and bust cycle. Instead, it's about finding a sustainable balance that prioritizing meaningful activities while effectively managing the impact of symptoms and the consequences. The reality of ME is that PEM results from an underlying physiological disease process that remains poorly understood. Until there is a cure, the goal is not to eliminate PEM, just as the goal in type 1 diabetes is not to restore pancreatic functioning. Both conditions stem from biological dysfunction, and the focus is on managing symptoms while preventing further harm to the body. The focus is on balancing activities and symptom exacerbation. Achieving this balance creates a more stable baseline, allowing for participation in prioritized activities with predictable outcomes. This approach fosters improvement in daily living and reduces the trauma on the body system. I will use a bucket analogy to describe functional capacity and baseline stability. Some patients may prefer analogies such as an iPhone analogy, iPhone 2 versus 15, or spoons, or a battery, each serving different explanatory purposes. In this image, I want to illustrate that people without PEM or before their COVID infection could manage a full bucket of daily activities without the water level overflowing. For those with PEM, their capacity for activity is significantly reduced. Depending on their severity, even basic tasks can fill their bucket to the brim, leading to the consequences that are out of proportion to the exertion. Functional capacity refers to the range of activities you can perform without overwhelming yourself or causing undue strain. It's essentially to understand what activities can you do without causing your bucket to overflow. And baseline stability refers to the safe zone of activity you can perform without reaching your limit or causing these consequences. It's essentially about determining What is the safe zone or the threshold before your bucket reaches its limit? The bucket for an individual with PEM shows a limited activity reduced to ADLs. This person's functional capacity often exceeds the brim of the bucket with even minimal activity, and their baseline stability is narrow and unpredictable. Minimum exertion exceeds the baseline threshold and results in PEM. I hear from many of my patients that have PEM that they say that they have no idea where their baseline is, that their bucket is constantly overflowing. Everything triggers PEM. And that is an absolutely valid statement. I hope that by analyzing activity and rest, we can find small, even narrow baseline so that activities can be performed with as few symptom consequences as possible. The bucket described in the previous slide can be separated, in my opinion, into 3 distinct categories representing physical, cognitive, and social emotional exertion. Most individuals without significant health concerns can switch between these categories without noticing many consequences. For individuals with PEM, their buckets are highly sensitive to exertion, where even the smallest stressor can lead to a disproportionate symptom consequence, which is the inherent part of this disease. Unlike a typical recovery process, the water level in the bucket does not easily adjust or reset. Similar to a battery that never fully recharges, their capacity remains limited. Understanding how different types of exertion contribute to filling the bucket towards this threshold is crucial. When this threshold is exceeded, PEM is triggered, leading to the crash. This understanding of exertion categories, the water level, baseline stability, and symptom consequences offers insight to managing the boom-bust cycle of this disease, and it can provide some level of control over the activity choices and meaningful engagement occupations. For those that are focusing on physical exertion bucket and their body's response to stressors, using biofeedback measurements is an effective strategy to capture the baseline threshold with numbers and data. This method works well for individuals who understand their baseline zone and aim to stay within a certain measurable threshold. However, with PEM, this threshold is a moving target. The water level at the brim of the bucket is always shifting, and it encompasses more variables than just physical exertion. Cognitive and social emotional exertion is not easily captured in this biofeedback measurement strategy. While biofeedback is a helpful tool, it should be used in combination with pacing for PEM plan. I'm going to zoom in on a case story or case study of Sally. Sally is a 12-year-old girl who has been homebound for 3 years due to long COVID with PEM. She has been diagnosed with ME and comorbid conditions including POTS, MCAS, and hypermobility syndrome. Her initial COVID infection, which occurred at age 9, presented with mild symptoms and then intensified over the past 3 years. PEM caused her severe discomfort, leading to multi-day episodes feeling like her body is cemented. She experiences sensitivity to light, sound, touch, movement, and a worsening of all symptoms following exertion. Severe head pain is a constant issue, along with hypersensitivities. POTS results in dizziness, lightheadedness, and blood pooling in her extremities. Her hypermobility causes her joints and her vertebrae to hyperextend and sublux, leading to sore joints. Fatigue is a persistent problem, leaving her feeling worn out and unrelieved by rest. Autonomic dysfunction causes her heart rate and her blood pressure to fluctuate with position changes. She also struggles with sleep, including difficulty transitioning in and out of sleep, insomnia, and she startles awake throughout the whole night. Prior to her illness, she was an active family member, a student, a friend, and an athlete. Currently, her condition severely limits her activities and engagement in daily life, leaving her future uncertain. Sally's functional capacity remains limited to her self-care and hygiene routines. She requires assistance with multi-step activities such as bathing and hair washing. She needs materials set up and placed within her reach. She performs all activities while seated. She dresses independently, but requires assistance with retrieving items. She eats in her bed or at the bedside table. Eating in the kitchen or with others is beyond her functional capacity. In terms of mobility, Sally walks within her immediate environment, but needs to sit semi-reclined soon after. She requires a wheelchair if she travels further than her immediate bedroom, bathroom environment. Sally uses a bedside commode daily, with occasional trips to the bathroom, but these extra trips take away from her ability to perform other activities for the day. Sally struggles to achieve sleep. She needs medication to fall asleep and stay asleep. Regarding education, Sally works with a tutor 2 to 3 times per week, but their schedule depends on her symptoms. She often needs to cancel, cut her sessions short, and she needs to be semi-reclined or in bed for her lessons. Sally struggles to meet school expectations, so her parents and the school have developed an IEP focused on her core elements of learning. Sally misses her school interaction and her social interactions in general, but she understands that this is a luxury. She tries to stay connected with her friends, but finds it difficult to keep up with them. She relies on conversations with her family for social exposure. Accommodations and modifications can help decrease overall exertion and help a person perform their activities. Although oftenly used interchangeably, these terms have different meanings, especially in the occupational therapy world. The first step in managing exertion is to evaluate the to-do list. This involves removing all non-essential tasks and prioritizing the remaining ones. Using Sally as an example, we organize activities into 4 categories: the do, schedule, delegate, and avoid. Simplifying the to-do list by eliminating non-crucial tasks helps Sally manage her energy more efficiently. For instance, she might find that making a cake or wrapping her sister's birthday present was an activity she used to enjoy. It now falls into the urgent but not important category, which helps her delegate these tasks. This categorization is clearer for adults who have many duties and responsibilities. This chart helps adults with PEM organize their to-do list, focusing on prioritizing activities. For example, they might delegate a task like picking up their child from school to a neighbor. This allows them to focus on an important activity, such as helping their child with homework at a scheduled time later. Accommodations are tools and strategies to achieve a stated goal. For PEM patients, these strategies and tools focus on reducing the workload and create a more manageable environment for various activities. Here are examples of activities categorized by exertion types. Physical activity of showering can be broken into smaller steps. We can use assistive tools. We can use energy conservation techniques. For cognitive activities such as an educational lesson, simplifying the task, using memory aids, and focusing the environment, minimizing distractions are very good accommodations. And social emotional activities such as a friend hangout, scheduling social interactions, setting a time limit, emotional regulations, practicing deep breathing and mindfulness before and after a visit, And planning. Consider both the positive and the distressful emotions that go along with these social interactions. Sensory tools and strategies should be integrated into all of these categories. Controlling the environmental stimuli can enhance the effectiveness of all accommodations. These sensory tools can include sound-canceling headphones, weighted blankets, and other materials that reduce the intensity of stimuli, which is exerting for somebody with PEM. It provides a protective layer for managing exertion and activities across the cognitive, physical, and social emotional activities. Here are just some examples of accommodations for education. Extending time, using flexible attendance, frequent breaks, home tutoring, assistive technology, quiet environment, and reducing physical activity. Remember, the goal for supporting people with PEM is to simplify their workload. Even with a well-developed plan that includes tools and strategies, individuals with PEM may still be functioning beyond their capacity. Therefore, it's crucial to modify goals and simplify daily activities to stabilize their baseline and to enhance their functional capacity, even if it's at a lower level. Modifications focus on the goal and adjust the criteria to make the task or the activity achievable. This involves eliminating, reducing, and delegating work. This is removing items from the to-do list and adjusting the goal achievement criteria. Each goal is tailored specifically to meet the individual's need. Here are some examples of modifications to a goal for different exertion categories, depending on the child's functional capacity and baseline stability for that time period. Physical. The original goal may be for the child to shower. Modified goal is just for the child to have a clean body. This may be used with having a sponge bath or just washing individual parts or washing the hair separate from the body. There are many ways to achieve this new goal of having a clean body. Cognitive. The original goal is for the child to have an education lesson. The modified goal is just to have stimulated thoughts and mind. This might include having the child watch a YouTube video on a topic of interest or learning a skill related to a hobby or a craft. And then social emotional, the original goal may be for the child to have a friend hang out in person, but the modified goal is for the child to communicate their feelings and express their thoughts and ideas through a variety of communicative methods and also with people that are closer to their social group. These activities are experienced in different methods and formats, but the focus should be on how to take the elements of the original goal and modify them to meet the child's current needs. And here are some examples for the education setting. Simplified assignments, reduced workload, alternative assessments and evaluations, modified curriculum, grading adjustments. And it is crucial to emphasize that delaying the education plan must be considered. Health should be prioritized over education. As an education is a lifelong process, and for kids with ME and long COVID, becoming a student cannot be pursued when it exceeds their functional capacity. It is essential to assure that they can perform and maintain daily living activities before adding educational activities to the picture. Additionally, when educational goals are being introduced, their performance should be continuously assessed to align with their current capacity and well-being. As medical providers, it is our responsibility to advocate for our patients' health. That includes documenting their functional capacity and disability to school staff. Immediate and delayed symptoms. As previously explained, PEM is a symptom of physiological dysfunction. The chemical responses produced circulatory responses the changes in oxygen level, and many other factors influence how an individual experiences full body symptoms. These symptoms can change over time. The individual will experience immediate symptoms as part of the initial stressors of exertion, which then evolve into a delayed symptom set of symptoms that are completely different from the initial ones. Immediate symptoms, these are the ones that are the warning signals indicating that the individual has overexerted and should stop the activity. They serve as the stop signs to prevent further exertion. Delayed symptoms are typically what we would indicate and refer as the crash. These symptoms manifest after certain periods, indicating how long it takes for the impact of the consequences of the stressor to appear. The nature and timing of these specific symptoms can vary greatly. It is crucial to recognize that children may not be able to verbally express these symptoms. Instead, these symptoms may manifest as changes in behavior rather than the intense chronic illness with debilitating symptoms. So this chart is an example of identifying the immediate symptoms of PEM. This process is something I implement with all of my patients, as their symptoms can frequently change over time, which is typical with chronic conditions. This method helps in tracking symptom progression, monitoring the progress of medication trials, and tailoring activities and medication to manage PEM more effectively. I've asked Sally to describe her symptoms in each of these categories. She identifies immediate cues, the stop signs, for her PEM symptoms and specifically breaks it down when she's done too much. The physical exertion section is when she takes a shower. She typically feels her heart rate increasing. She feels dizzy and lightheaded, tired, dragging, and worn out. And afterwards, she usually collapses in bed, still in her towel for hours. Cognitive exertion. During the 20-minute math lesson with her tutor, Sally's head starts to hurt. She struggles to find words and express her thoughts. She describes her head as being full of sludge. And she also shows overall body pain with significant discomfort in her head and neck, what other patients might describe as a coat hanger pain. Social emotional exertion. During a friend hangout, Sally notices her stomach is hurting, her ears are buzzing, and she finds it difficult to stay focused in a conversation as her mind can't process language. And this chart is an example of Sally's delayed PEM. Here, Sally describes the three most functionally interfering symptoms. She feels 12 to 48 hours after exertion. Some patients may even feel this further out than 48 hours. For physical activity, such as a shower, Sally reports feeling achy all over with generalized body pain, resembling flu-like symptoms. She feels a heaviness throughout her body, like she's been poured with cement. And she experiences a headache as like her head is being squeezed. For cognitive exertion, such as the math lesson, she gets a migraine sensitive to lights and sounds type of pain. She becomes extremely tired and sleepy and finds it hard to remember words. And she finds it hard to even tell her mom what she is needing. For social emotional activities such as the friend hangout, she feels heaviness all throughout her body, and she experiences achiness in sore joints and tender lymph nodes. By documenting these symptoms, the patient can better understand their patterns and predict their outcome for future activities, aiding in their management of delayed PEM. Once I have a clearer understanding of the symptom time course, including the immediate and delayed PEM, Sally and I work together to analyze the activities and her priorities. We start identifying her functional capacity and her baseline zones. Here's a chart where I asked Sally to identify activities she performed over the past week in the different exertion categories. Physical, she jumped on a trampoline, she took a shower, and she played with the dog. Cognitive, she worked on a math lesson. She listened to a social studies video, and she watched a documentary. And social emotional, over the last week, she attended a family birthday party. She hung out with friends and she messaged friends. Here is what I describe as my zoom in activity analysis, where I focus on one specific activity and dive into the details, and I start pulling out threads. For Sally, I am analyzing the shower activity in detail. I assess what aspect of the activities are challenging and pinpoint the specific exertion stressors. By understanding how her symptoms are triggered and made worse, we can identify tools and strategies and changes to the goals for this activity to minimize the symptom consequences. So examining the exertion stressors involves the following factors as they influence and impact how activities are performed. So here's examples of assessing exertion stressors. Time. What is the length of time spent on the activity? What's the time of day it is being performed? What's the time between activity and rest? Sensory. How does light, touch, sound, smell, taste influence the intensity of the activity experience in the sensory system? How loud is the ceiling fan in the bathroom, or bright are the lights? Or how intense are the smells of the shampoo and soap? Often overlooked sensory component also include proprioception, which is the body's ability to interpret itself in relation and coordination, and interoception, the feeling of internal regulation, such as hunger, bowel and bladder needs, and other self-regulation needs, and then processing this internal and external information. Orthostatic response is the positioning against gravity, such as being upright and weight-bearing. It's the heart rate and blood pressure biofeedback mechanisms. And environment, recognizing the effects of the weather. What's the wind, the barometric pressure changes, and the humidity? Chemicals and pollutants, molds and allergies. How are all of these demanding on the body? By carefully analyzing these exertion stressors, we can develop tailored strategies to manage Sally's symptoms for the specific activities. And here I zoom out and I analyze the activity for the week for Sally. I ask her about the most important activities she has for the upcoming week, which I refer to as anchoring activities. I ask Sally to list her priorities, and we categorize these activities into categories. We look out for the activities that may come too close or overlap, and we avoid performing the same exertion category back to back, which I refer to as dipping from the same bucket. Finally, we plan rest periods and determine how each activity will require preemptive and recuperative rest specific to the exertion. And in this slide, we'll illustrate Sally's symptom time course through the activity of shower and rest. We analyze the physical activity of showering. We focus on the immediate and delayed time course. To preemptively support the symptoms like dizziness and lightheadedness, we can discuss pre-rest techniques such as extra hydration or heart rate management and trying to calm the autonomic nervous system. And this may include planning the shower during the optimal time for her beta blocker or other medications, and even examine what the weather is like for that particular time of day. We identify effective strategies to address anticipated symptoms. And with rest preparation, we use accommodations and modifications during the activity and then aggressive rest afterwards. We're able to determine that the shower can be completed within her functional capacity, but with a lot of support. It may approach the upper limit of her baseline, but generally it does not exceed her threshold, keeping the consequences of this exertion minimal. And in this final chart, Sally and I examine how she wants to do more than just plan for a shower. We add her cognitive and her social emotional prioritized activity for the entire week. We plan for the activities and rest periods before and after the activity. Sally and I spend a lot of time reviewing her past weeks and tweaking that information to develop plans for future weeks or months. If a special event is coming up in Sally's life, this type of preparation allows for Sally to game plan it so that the event is high on her list, and managing her symptoms It may be adjusting her medications and adding extra tools and strategies, but it's also really important to communicate her plans to others so that they can adjust their expectation or demands on her accordingly. And very quickly, the last is for the types of rest. For those without PEM, there are two types of rest typically. Recharging rest for relaxation and convalescence, and this is for recovering after an illness or an injury. But for those with PEM, it's radical rest, is an aggressive energy conservation process that involves past, present, and future exertion. The preemptive rest is a preventative measure, a planned, scheduled strategy for reducing or preventing symptoms and stabilizing baseline functioning. And then recuperative rest is necessary after exceeding the baseline threshold. This rest following a crash focuses on returning to baseline functioning. Both of these rest periods are used for preparing the body for exertion and healing from symptom response to the stressors. This is not a form of avoiding exertion. It's rather a proactive strategy for utilizing tools, support, and techniques, which I called support kits, to decrease the symptom load and limit exertion for improved functional outcomes. So thank you. Thank you for your attention, and I appreciate this opportunity to share a very meaningful topic in my life. And I encourage you all to continue learning about ME and long COVID, especially with PEM.
Amy, that was wonderful. I learned a lot. That was a lot of new information for me. Was that website you listed on that last slide, is that a way to contact you, or can you tell us more about that?
Yeah, that is my private practice. I work a lot with Bateman Horn Center in Utah. So a lot of my information is already on their website, but I also have a private practice, and that's where I see my patients through telehealth. So it's at it's www.ot, the number 4me, meaning myalgic encephalomyelitis.com. And so you can reach me there. I collaborate with other professionals. My goal is to teach you guys how to care for these patients because there aren't enough OTs and PTs for the needs of this patient. We need to get even speech language pathologists and social workers and school therapists, everybody out there to know about this debilitating condition.
That was great. I feel like there's so much of that that's applicable to a lot of other things, especially in the world of developmental delays. And, developmental delays or not, I feel like I can organize my life better with a lot of what you talked about. I'll leave it open just for 2 minutes here for questions. One of our participants put information in the chat if anyone's interested. The Utah Department of Health and Human Services is discussing a bill very relevant to the pediatric world. At 2 p.m. tomorrow, there's some information listed there. They're discussing a bill that would allow parents to opt out of newborn infant screening. I think there'll be a discussion around that, and there's further information there if that's anything anyone is interested in contributing their opinion on. Just leave it open for a minute here. I'll put the CME code in the chat one more time. So it's 43195. You can call that phone number that we'll send out. And just remember to claim it by midnight tonight. And with that, Amy, I'll just say thanks. That was really wonderful. Thank you so much for joining us all the way from Chicago.
My pleasure. Thank you so much for having me.